I'm really honoured, and I'm so excited to be at the Mental Health Music Festival, which is really gaining international recognition. There was an article about it in the Cambridge University Alumnus magazine, and it mentioned I was speaking with a huge photograph of the Pointer Sisters. And, you know, I have a special affinity with the Pointer Sisters because people don't know that their debut single in the US came out the same year as my first scientific publication. It was only a few years back. So let's get to talk about cognitive enhancement. But what I want to begin by is discussing really the pharmacy of mental illness. And just to point out that, you know, for conditions such as depression, we really have an astonishing range of treatments. Many of these treatments are lifesavers. On the other hand, people criticise many of these drugs because they are, after all, of limited efficacy. And it's not altogether clear after the first-line therapies what you use, whether you use the old-fashioned tricyclic drugs or the monoamine oxidase inhibitors, whether you combine them with other drugs to try and somehow improve their effectiveness, and really what the comparative role of other forms of therapy might be, including, for example, deep brain stimulation, electroconvulsive shock, which is still used for severe depression, and importantly, I think, cognitive therapy, which is an important treatment for mild depression. But you know, one of the major criticisms of these drugs is that even when someone responds well and they go into remission from depression, they still suffer cognitive impairments. They have problems with their memory and they have problems concentrating. So the drug really doesn't do a perfect job at all of rehabilitation, even in the best cases. And this is true when you look at a whole range of psychoactive substances or drugs, which I was called on to do as part of a UK project on brain science and the future of drugs, or drug futures. You know, what's going to happen in the next 20 years in terms of new drugs appearing, which will be of use in psychiatry. One useful starting point is to define a number of categories of these drugs. So mental health medicines would be one, and that includes the antipsychotic drugs, antidepressants, as I just mentioned, and anxiolytic drugs. Another category, of course, is the recreational drugs, which we know about, drugs of abuse, such as heroin, amphetamine, and cocaine, and others. And a third category, which I think is emerging, although there's an intriguing overlap with these other two categories, of cognition-enhancing drugs. And that's really going to be the focus of my talk today. Now, what do we mean by cognition? And what's the message of my talk? The message is, in the future, we will see new cognition enhancers, and it's quite likely that they will be used as treatments for mental health. Now, by cognition, I've drawn a few boxes here which illustrate the different aspects of cognition. The input, for example, perception and wakefulness and attention, and then the representation of knowledge in the brain using working memory and long-term memory, and then how we act on that knowledge in an executive way to make decisions and plans and produce behaviour. And there's no doubt that there are a number of cognitive syndromes in need of treatments. You're all aware of the degenerative diseases, the dementia, such as Alzheimer's disease, and also Huntington's and Parkinson's disease, acute brain injury and stroke, but also schizophrenia, depression, the sequelae of drug abuse, attention deficit hyperactivity disorder, autism, and anxiety states. They all carry with them cognitive impairments of different but sometimes overlapping sorts. And this has led to a new interest in the pharmaceutical and the biotech industry in cognitive enhancers. And there are a number of companies trying to produce drugs with a variety of different strategies. And recently there were 40 potential cognitive enhancers in clinical development. Now, cognitive enhancers can be categorized in different ways, and what I'm not going to talk about today is the neuroprotective strategy, which is probably going to be important for Alzheimer's disease. So in Alzheimer's disease, as you know, you have these specific forms of neuropathology as a result of rogue proteins, which are deposited in the brain, leading to plaques and tangles and cell loss in the brain. And these can be halted probably by vaccines possibly, but by enzymes also which cleave these rogue proteins as they're being laid down. So this neuroprotective strategy is not likely to be that useful in neuropsychiatry, but it's definitely, in a sense, a form of cognitive enhancement. For schizophrenia, it's recently been recognized that the jigsaw of the symptoms of schizophrenia, which include, of course, the positive and negative symptoms and other emotional symptoms, also there's an important piece called cognitive symptoms of schizophrenia. And this has been recognized as important because, again, even when schizophrenia is treated effectively in terms of antipsychotic actions, it leaves a residual cognitive deficit which prevents full rehabilitation of a patient who, for example, can go back to work and act effectively in the community. So this has become a sudden focus for importance in the treatment of schizophrenia and other neuropsychiatric disorders. And this matches up with the fact that there are, after all, diverse organic signs of damage in the brain in schizophrenia, often quite subtle, including, for example, shrinkage of structures such as the hippocampus, which is shown here, and also cellular and molecular changes in those parts of the brain associated with higher cognition, for example, the frontal cortex. Now, the frontal cortex and the hippocampus are also importantly involved in neural circuits or systems in the brain. On the right-hand side here, you see a schematic depiction of the reward system in the human brain, which involves connections between the hippocampus and limbic system and the frontal cortex and a part of the brain called the striatum here. And this is shown diagrammatically as this red-hot loop here because of its emotional significance. But there are other parallel loops involving the frontal cortex which mediate cognition. For example, in the dorsolateral prefrontal cortex to other parts of the striatum. And this is where some of the deficits are seen in conditions such as schizophrenia and depression. Now, these brain systems are also importantly modulated by rather ancient, primitive neurochemical messenger systems from the hind and midbrain. These systems, such as the dopamine system, the noradrenaline or norepinephrine and serotonin and acetylcholine systems, probably provide states like mood and arousal and actually stress, which powerfully interplay and affect the cognitive functioning of these higher centers. So let's focus on just one of these systems for the moment, the dopamine system. And we know in the human brain, this branches from the midbrain into three main areas. The striatum, where dopamine loss is associated with Parkinson's disease and movement disorder. Part of the brain called the ventral striatum, or the nucleus accumbens, which is known to be associated with reward learning and also, importantly, drug addiction and probably where antipsychotic drug effects are mediated. And finally, the projection targeting the frontal lobes, mediating cognition, possibly deficits in schizophrenia, Parkinson's disease, and also attention deficit disorder. Now, I'm just going to tell you a little bit about how these chemical messenger systems actually work in the brain. The brain is comprised of nerve cells joined together. But of course, they don't actually touch one another. Nerve cells are arranged so that they are close to one another, their connections, but the electrical impulses which pass down nerve cells can't jump the gap between them and have to use chemical messenger systems, such as dopamine, which are released onto receptor molecules made of protein on the second nerve cell, or the postsynaptic cell. And we now know how many drugs work using this basic model. So, for example, cocaine, amphetamine, and Ritalin, used in the treatment of ADHD, all work in much the same way. They tend to increase the level of dopamine in this gap. And they do it either by blocking the reuptake of the chemical messenger back into the presynaptic, or the first nerve cell, or, as in the case of amphetamine, they also facilitate the release of the chemical. So in other words, these drugs boost the action of dopamine. And actually, antipsychotic drugs work almost in the opposite way, by preventing dopamine from overstimulating these receptor molecules. Now, the effect of dopamine is basically like turning up the volume control on a radio. As you turn it up to hear the fidelity of the signal better. They amplify the signal, as you see here, like this, so that you get a better signal-to-noise ratio. And these receptor molecules are on these cells of, for example, the prefrontal cortex, and they essentially optimize the output of this cell. They put it into a range of maximum fidelity. And so a lot of animal and human work has shown that we have an optimal level of dopamine activity, for example, in the frontal cortex for cognition, for things like working memory, which is when you remember a telephone number, like 365878. You have to hold that in working memory. And to do that efficiently, you need neither too little nor too much dopamine. And it's been shown that things like stress can impair working memory, and the effects of stress can be offset by drugs which move the function back into the optimal range for dopamine. And this has been shown in simple tests of working memory for rats, where they just have to remember one thing, which is what they did on the last trial. Did they go to the left or to the right? But either too little or too much dopamine is bad for cognition. And Danny Weinberger, a couple of years ago, showed you how individuals, normal, healthy volunteers, normal individuals, show variations in their optimal levels of dopamine in the frontal cortex caused by their genetic makeup. So there is this gene, catecholamine, which exists in different forms in different people, to either promote a relative deficiency or a relative excess of dopamine in the frontal cortex. And what Danny showed, which is so interesting, is that on a test, a cognitive test of frontal lobe function, which I'll describe later, a drug like amphetamine, which, as you remember, releases dopamine, for these volunteers actually is of benefit to those patients with low dopamine, or subjects with low dopamine in the frontal cortex. But actually, if anything, in those individuals with optimal dopamine, if anything, it made them a bit worse. And so this is fully compatible with this kind of inverted U-shaped optimal function. And it's of great relevance, I think, in the future to tailoring drug treatments individually to people, possibly based on their genetic makeup, which may influence how well the drug works on cognition. Now, in schizophrenia, the general hypothesis is that there's too much dopamine in these ventral striatal and dorsal striatal regions. So we've got a problem there. There's too much, there's an excess. And there has been a view that maybe there's a little too much in the frontal lobes, which, as you saw, because of stress, puts you into a bad area for cognition. But work with brain imaging has also revealed the paradox that in the frontal lobes there may be too little dopamine in schizophrenia. And this provides us with a real problem in terms of treatments. Because take a drug like haloperidol, which is a typical antipsychotic drug. It blocks a specific class of dopamine receptors. It's a pretty good antipsychotic treatment. It turns down the gain on the radio, literally. But of course, you don't want to reduce dopamine function in the frontal cortex anymore because you'll just make things worse. And so there's a very real issue of improving antipsychotic effects at the cost of impairing cognition with this drug. So you can get the balance right between the subcortical effects of the drug and its cortical effects. So in other words, how can we reduce this activity but also boost this activity? You see, it's a bit of a problem. You can't easily do it with one drug. Even the so-called atypical new modern antipsychotic drugs, which you see are very fancy, look how complicated they are. They have this effect of reducing dopamine function subcortically, and it's been argued that their other actions help to actually increase dopamine in the frontal lobes. But nobody quite knows how it does that, and in fact, many of us, there's a lingering suspicion that the reason that patients do better on this drug with cognition is simply because of fewer side effects than with haloperidol. It doesn't actually produce positive benefit. So how are we going to produce positive benefit in these domains of cognition which are impaired in schizophrenia? Speed of thinking, attention, working memory, verbal learning and memory, visual learning and memory, and executive functions, reasoning and problem solving, and above all, the complexities of social cognition, figuring out what the other person is thinking. Well, we use a neuropsychological battery which we invented based on studies in animals so that we could go between animals and humans, the so-called Cantor battery. And this shows 3 of our tests of frontal lobe functioning. And I'm going to be talking about some of these in this lecture. Now, one of our tests, which I know you can't see very well at the back, is a test based on optimal foraging in animals. The subject has to open boxes on a screen to find these wonderful reward tokens, which they can stack up on the side of the screen. It's a touch-sensitive screen, so they interact with it directly. And they mustn't, though, return to a box which has previously had one of these wonderful tokens. So you have to keep in mind where you previously found the tokens and use working memory. Now, we know that damage to the frontal lobes, these are patients with acute brain injury, particularly to this dorsolateral area, produce massive deficits in terms of errors on this task. So this is a test of dorsolateral prefrontal function. We also know that you can improve function on this task in several patient groups. In Parkinson's disease patients with their L-DOPA therapy, it improves their cognition as well on this test, working memory. And we've even shown in normal volunteers who in fact were Cambridge graduates, quite high IQ, they came into the lab, they were given Ritalin, methylphenidate, they did better on this test when they tackled it for the first time. Quite a remarkable result, which leads me to not be surprised that it works also for ADHD. It improves cognition even in normal subjects. And it does so by enhancing dopamine and noradrenaline in the brain, and also by improving the efficiency of a neural network, including the frontal lobe and a part of the brain called the parietal cortex. So Ritalin seems to make the brain more efficient in performing this task and improve performance. If performance is well practiced, though, it can make things worse, which is a little bit of a caution. Tests of cognitive flexibility commonly used to test frontal lobe patients, like the Wisconsin card sort test. In the Wisconsin card sort test, you're given this pack of cards which varies by colour, shape, and number of symbols. And you have to figure out the rule on the basis of trial and error feedback that the clinical psychologist has in their mind. And frontal patients learn this rule pretty quickly, but they have real problems in learning to switch the rule when the feedback changes. So they perseverate, and so do schizophrenic patients. Now, if you give this test to monkeys, they throw the cards up in the air and do unmentionable things to them. So we invented a test where we presented the same kind of test on a touch-sensitive screen with shapes and lines. And we actually used exactly the same test to test human patients so that we could achieve a real translation. For our marmoset monkeys here, and I'm not going to describe this work in detail, but also some of our graduate students went off and invented a similar test for rats and mice. So for rats and mice, they get them to burrow through this sand, which is either coarse or fine, and is perfumed in different ways. And it's either the perfume or the coarse texture of the sand which is predictive of where the food is. And so you can show cognitive flexibility there too by switching from attending to the texture to the smell or vice versa. And exactly the same things seem to work. It also depends on the frontal lobes in these lower animals. But going back to human volunteers, we found that Ritalin dramatically improves cognitive flexibility when you do a shift on this task. Subjects solved the task in hardly any errors, which is intriguing. There's a small cost to this because it makes them also a little more distractible, but it produces this cognitive flexibility which can be beneficial. And putting these facts together, we thought, well, maybe this would be an interesting type of approach to bring to schizophrenia. How can we boost frontal lobe function in schizophrenia using a drug like Ritalin, which affects dopamine and noradrenaline? But there's a real problem here because, of course, what we don't want to do is make the psychotic symptoms worse, which you're in danger of doing. So we had to look at other drugs which have stimulant properties but don't have this subcortical effect on the dopamine system to the same degree. And so we thought we'd test this drug modafinil, which is licensed in the treatment of narcolepsy. You know, when you drop asleep suddenly on the lecture podium, modafinil stops you doing that. Intriguingly, although the drug's very effective, nobody is quite sure how it works, although it's thought to have some effect on these dopamine and noradrenaline systems. Well, we tried the drug again on a test battery, including tests like working memory and flexibility, and also tests of planning, like the so-called Stockings of Cambridge task, where you're asked to look at this puzzle here and look at these coloured balls. They're like snooker or pool balls in stockings, and you have to figure out how many moves it takes you to move these balls around to reach the goal arrangement in the top. So can anyone do this? It's 5 moves, actually. Okay? It takes even a normal subject a while to figure this out. And you just touch the one which you think it is. Now, astonishingly, again, we had in our normal volunteers, modafinil improved performance. These subjects were not sleep deprived, and the effects are quite dramatic, as you saw here. In fact, this achieved a deal of notoriety in the British press, these kind of results, because they started thinking about improving normal subjects' function, you know, which is a controversial area. And as you see here, there's a cartoon which is basically saying to George Brown, can't you take some performance-enhancing drugs? But that is an ethical issue we have to contend with. However, when we gained permission to take modafinil into schizophrenia, adding modafinil to subjects to test them in a lab, to just test the proof of principle. Can you improve cognition in schizophrenic patients in the same way as you can normal subjects? The answer is yes. And as you see here, these schizophrenic subjects showed a dramatic improvement in the cognitive flexibility task. The normal decline in performance over the tricky parts of the test is completely washed away by modafinil. Now, of course, I'm not arguing that we should treat schizophrenics with modafinil, but it does show you the proof of principle that there is something there to improve, in theory, something to aim at. Now, we also gained inspiration from considering ADHD. And I'm not going to describe this complex slide in any detail, but there's a lot of understanding based on gene-environment interactions in ADHD, neural circuitries which are affected, which include the dopamine and noradrenaline systems, and particular endophenotypes or cognitive structures which may be at the base of ADHD. And one of these is the ability to inhibit impulsive behavior. Now, what do I mean by impulsive behavior? It's when you have to stop yourself blurting out something stupid at a party, or stupidly getting up and making an exhibition of yourself at a football match or something like that, or being naughty at school, possibly. In the lab, you can test this with the so-called stop signal reaction time task. And how this works, and you can do it in rats as well as humans. I'm just going to show you the human task. Is you're told, right, now when you look at the computer screen, you have to respond either right or left, according to the arrow, as fast as you can. But sometimes you're going to hear a beep. And when you hear that beep, you must not respond on that trial. Now that beep can come either immediately after the imperative signal, or it can be delayed. So just as you're pressing the button down, the beep comes and you have to, stop. And of course, ADHD individuals have great difficulty in doing this. Now, this requires executive control coming from the frontal lobes. And in particular, this imaging study shows one particular part of the frontal lobes, the inferior frontal cortex, shown on the extreme right here, as being very important in this behavior. Now, this shows you the effect of Ritalin in adult ADHD patients. You see, here's the deficit. They're slower to stop. Give them Ritalin and they're okay. And Ritalin selectively improves stopping and not going. So it really does enhance this inhibitory control. Intriguingly, we found that another drug, atomoxetine, which really only affects noradrenaline, and mainly probably in cortical regions. It doesn't have this strong effect that Ritalin does to increase dopamine subcortically. So this would be a much safer kind of drug to enhance cognition, because you would tune up the cortex without tuning up the dopamine system, which may exaggerate psychosis. And we recently showed that as well as atomoxetine improving performance in normal subjects and in ADHD individuals, it enhances the activity of this same part of the brain, which you can see up in the extreme right-hand corner there, the inferior frontal cortex. So using this combination of techniques, we're able to demonstrate in human subjects where a drug such as atomoxetine is working to produce a specific form of cognitive impairment. And by the way, schizophrenic patients are also impaired at stop signal inhibition. So this may be relevant to them. Now in the second and last part of the talk, I want to go on to talk about networks and a completely different strategy. So these diagrams show the real brain in terms of neurons. This is what it really looks like. See how complicated it is? 10 to the 11 nerve cells and 10 to the 14 connections. It's a lot. This is an abstract network produced by analysis of brain imaging data in the middle. And this is a kind of artificial network, a computational network. And one important principle in a network is that networks can learn. And there's this phenomenon called long-term potentiation, or LTP, which has suggested that when neurons fire together, they wire together. and make associations. And this is the basis of learning. And we can affect this learning chemically by using the chemical messengers which act as turning on the switches at these nodes in the network, either excitatory or inhibitory. And some of the excitatory switches work through a chemical called glutamate, which produces very fast signaling. And glutamate works through a number of receptors, but two in particular I want to mention here: the NMDA receptor, which is particularly involved in learning, and the so-called AMPA receptor, which is particularly involved in fast signaling. Now, you will know from previous lectures here of the central role of glutamate and NMDA receptors in schizophrenia. There's a lot of converging evidence. Pharmacology, pathology, but also genetics, because some of the best genetic candidates seem in various ways to target the NMDA receptor and glutamate transmission. So you can see where this is going. There are a number of consequences of hypofunction of the NMDA receptor. Your network is going to be weaker. Learning is going to be impaired. Actually, the AMPA receptor won't be activated properly, and there will be a dysregulation of glutamate. So the brain may try to overcompensate for the lack of function by producing too much glutamate, which gives you another inverted U-shaped situation. Too much is bad for you as well. And this has partly underlaid the strategy, completely new strategy, of glutamate treatments for schizophrenia, the first of which works in an unusual way, the so-called mGlu-R23 presynaptic receptor, a drug which actually reduces glutamate release. So it brings glutamate back into a normal range. And the excitement here is that in a recent trial carried out in Russia, Eli Lilly made this drug, and they did this trial in Russia, which showed that this drug, so-called LY compound, produced benefits compared to placebo almost as good as the atypical and popular antipsychotic olanzapine. Quite remarkable. And it also did a similar job for negative symptoms, and it didn't produce increased weight gain, which is an unfortunate side effect of olanzapine. But what does it do for cognition? We don't know yet. Does it improve cognition, or does it make it worse? That's going to be an important focus. Now, another approach is to modulate AMPA receptors to make them work better. And you can do that with drugs as well. So you get a bigger bang for your buck with this added drug, which makes the receptor work better. And these drugs are so-called ampakines. It's a new class of drug which has been shown to produce quite astonishing improvements in memory function in monkeys. So in this study, monkeys had to remember pictures, maybe 2 pictures, 3 pictures, 4 pictures, up to 10 pictures, over delays of time. And what you can see here in the top is normal performance. You can see the forgetting curve over time as the task gets more difficult with the different number of items. But then when they're given this drug, look how much better the performance is. It's quite astonishing. It's a dramatic improvement. So these drugs are being produced which may actually target cognition. And there's an early study by Gary Lynch who's shown in human subjects with one of these drugs, in elderly individuals whose memory wasn't too good, a quite dramatic improvement, dose-related improvement with an ampakine. Now, this was a while ago, so why isn't this drug being used now? The answer is that it turned out to have side effects. But sooner or later, they're going to get rid of those side effects, and some of these drugs will emerge as treatments for cognitive failure. There are also drugs which can help us forget. Now, you might think that's pretty stupid. I don't want a drug that helps me forget. Sometimes you do. Sometimes you might want to forget if you've been a victim of a trauma or a disaster, Or if you're a drug addict who wants to forget about all those stimuli which give you the cravings. Or if you've got anxiety problems, you're scared of spiders or heights. And recently, animal work has shown that you can help forgetting, not only by what's called extinction, which is a behavioral procedure, but by adding in there a drug which makes the NMDA receptor work better too, so-called D-cycloserine. And this has been used in a recent trial of patients with vertigo. And they're tested in a lab environment, must have been quite terrifying, using virtual reality to simulate their fears. They were taken up in a virtual situation in a high building, 1 floor up, 2 floors up, 19 floors up. And they measured anxiety and showed that this caused anxiety. They then combined this with some psychological therapy, and it had an effect. It reduced their anxiety by about, 10%, as you can see here, even as they're going up in terms of the virtual floors, from 1 to 19. But when they added on board cycloserine, this potentiated the cognitive therapy. It made it work better. So one of the messages we have for the future is that we may have to optimally combine psychological with drug treatments to produce the best effects. And this is one of the keys for the future. We have to learn how to do that. Well, let me wind up with another few snapshots of where I think things are going in the future. A few future-looking things, both pharmacological and psychological. So this is a typical SSRI, an antidepressant drug, Prozac, fluoxetine. You can see, its neurochemical actions here in this icon. But intriguingly, many of these drugs are now being shown to work by completely hitherto unsuspected actions. So this drug doesn't only work on serotonin, it seems to affect neurogenesis in the hippocampus. And the hippocampus, remember, is an important part of the brain for memory function. And it's been shown that stress in the hippocampus can affect its wiring. But even more exciting, this stress effect can be ameliorated by neurogenesis. In other words, the production of nerve cells, even in the adult brain. This is one of the few parts of the brain which shows this effect. But environmental enrichment, like the music festival is, or exercise, so rats in running wheels can grow their hippocampi, or antidepressant drugs all enhance neurogenesis in the hippocampus. And that may actually produce some benefit through growth factors like BDNF to promote optimal functioning of this memory structure. Lithium is another drug. Nobody knew how it worked, but now it's been discovered that it affects intracellular cascades, which are also involved in plasticity. So this is a very exciting discovery. And there are also psychological discoveries which we need to take account of. So this is the learning test from Cantab, our battery, which is so sensitive to hippocampal functioning. And it's a test which kind of epitomizes what the hippocampus does, which is remember where things are. This is one of the main functions of the hippocampus. Objects in space, where things are. It's one of the early deficits, as you'll see, in Alzheimer's disease. So here's the test. You're shown these little stimuli that come on, these little icons in different places. And then at the end, we say to you, where was that one? It was in the northeast box. And then the next one, and then the next one, until you've learned all 6. Now, you can have another go until you get it all right. And I can tell you, most of you will make relatively few errors on this task. The task is sensitive to hippocampus because brain imaging highlights the hippocampus when subjects do this task. And the important thing is that it's not only very sensitive to Alzheimer's disease, so these are errors on this axis. These are Alzheimer's patients. Many of them fail the test, but they do so with a whole lot of errors here compared to normals. But intriguingly, in patients at memory clinics who think they may have Alzheimer's disease, they've got subjective memory problems, this test divides them into two groups, like no other test we know. One group who are impaired, like Alzheimer patients, and many of whom go on to get that diagnosis. Another group who are relatively normal. So think about the utility of this. We could potentially, using this cognitive biomarker, pick up Alzheimer's and treat it before the damage is done. And we may take this approach even to mental illness. So in schizophrenia, this is the test I showed you before, the optimal foraging test for humans. And this is performance over lifespan. So this is when you're 4 or 5. There's 750 subjects in this. So the statistics are pretty cool. But this is when you're quite young. You make quite a lot of errors, but you get better, you see, when you're an adolescent. You get worse again when you're older. But this is an incredible ravine here. And note where you're best, 16 to 23. From then on, it's all downhill. Or uphill, as the case may be. But of course, this is a particularly susceptible time for schizophrenia. And indeed, it's been shown by an Australian group that poor performance on this test antedates the first episode in schizophrenia. So it's one of the cognitive biomarkers which may give you information about risk and the possibility of treating before the damage of the first episode. So just in summary, on time, Huda. So this is my summary slide. The working heuristics for predicting how drugs are going to enhance cognition. Well, it's going to depend on the disorder and the nature of the cognitive task, which in turn will determine which neural system's involved and how it can be modulated. So we know a lot about cognition in all its complexity and how it works in the brain and how to change it chemically. It's going to depend clearly on things such as the dose, which may vary for different people, and partly as a consequence possibly of different genotypes. Different drugs may be differentially effective in different people. And obviously, things like stress, arousal level, mood, fatigue are all going to have their influence. We do have to beware of inevitable costs of trying to optimize one thing and keep everything else okay. It's really hard to do that in a complex system, theoretically. Optimizing everything is tough to do, perhaps because that's the way the brain is set up. I hope I've given you some overall optimism that at least there's some activity in this area and that effective treatments are becoming available or will become available in the next 20 years. But I also caution that we will need to use these agents very carefully and in combination with strategies including cognitive biomarkers, early detection in other words, and also optimal behavioral training procedures. So I'd like to thank my group, without whom I couldn't do any of the work that I've described here. We have a whole lot of people who work on the animal side. I haven't described much of their work. They include people like Barry Everett and Angela Roberts. And then in our human team, my spouse, Barbara Sahakian, leads many of the clinical projects. And we've got a whole range of really bright postdocs and graduate students who are contributing in the ways I've described. So thank you for your attention.